Hello there. Here we are again, I hope. I say that because you may not realize this is just one of a series of episodes, each one with a different guest and a slightly different topic. If you're new to the Price of Pain podcast, welcome. I encourage you to check out some of our other episodes and see if anything catches your interest. And for those who already have, welcome back. We're doing our best to bring awareness to pain research and pain treatment, but also provide some content for you nerds out there like me who like to pass the time by learning something new. Speaking of, you're about to hear my conversation with Assistant Professor Dr. Emily Bartley. She's a clinical psychologist and the director of the Aspire Lab at the University of Florida. While it may be nothing new to hear that it's healthy to be positive, Dr. Bartley's actually using positivity and hope as a treatment for pain. She's a fun guest to have on. I hope you enjoy this one as much as I did. But first, how about this new intro graphic that Kat put together? Just one step closer to digitally enhancing my hairline. All right, Kat, let's get to it.
Welcome to The Price of Pain, brought to you by the Pain Research and Intervention Center of Excellence at the University of Florida. Let's join host Dr. Joshua Crow in conversations with scientists, healthcare providers, and industry professionals as we delve into the highly subjective experience of pain and the ongoing effort to reveal its influence on our everyday lives.
Yeah, so how long have you been in Price? I guess I never really asked you that.
I got here in 2012.
Okay, all right. And when you first got here, did you do a postdoc here also, or?
I did. There was a same T32. It wasn't called what it is now. It was kind of a translational pain science, and it was under Dr. Bob Yazierski. So he was the program director for that. Yeah. So I came in at that time and did a 2-year postdoc.
Where did it from?
Where I came from? So I was actually on internship at Duke Medical Center prior to transitioning down here to Florida. And then prior to that, I was in grad school at the University of Tulsa in Oklahoma.
Okay. And where's the connection with you and Dr. Pallett? Where did that, because that started before here, right?
Yes. We went to graduate school together at TU.
Okay.
So she started out in the laboratory. I'm not exactly certain what year, but she was an undergrad, and then decided to pursue a PhD and then stayed in the laboratory at that time.
Okay. All right. And so tell me about Duke a little bit. These are things, again, that despite working together, I don't think I've ever asked you about. So why not do it now?
Yeah, so for part of my degree in clinical psychology, we have to do a 1-year internship. And because I was interested in pain sciences, I tried to find an internship that would allow me to work in the field of chronic pain, because there's a lot of variety across internship sites. And so I'd been interested in Duke for quite some time. Frank Keefe worked there. There was a possibility of being able to work with him on a rotation. And so I don't know if you're familiar with clinical psychology, like internships, and in terms of how we have to go through that process, but it's like a match. Okay. And so you send off your applications, and then the sites rank you, and then you rank these sites after you get interviews. And so it's just a matching process. And then you...
Like med school, similar to med school.
Exactly, yes. And then you have a day where it's a match day, and then you wake up and you look at your email and you find out if you matched or not. And if so, then where are you going? So it's kind of exciting and anxiety-inducing at the same time.
So are you willing to share? This could be a taboo question. I've asked med students before, prior to match day, you know, and so this is, looking ahead, like, oh, well, what's your number one choice? And I've had people say, I can't tell you that, it would jinx it. So retrospectively, was Duke
was my number one.
So you matched with your first choice. That's awesome.
Yeah.
How often does that happen in clinical psych?
I'm not exactly certain on the statistics of that.
That's
but I would say that, if you are going to match, typically people match within their first, like their top 3.
Sure. And I think med school is pretty much the same way. But yeah, I think it's awesome just having been close to that process with people I know, not having to be part of it. It's harrowing, but at the same time, really neat to think that there is more than just the application process and the interview process on singular data points, that there's some kind of algorithm that says, okay, you, in comparison to all of the other people who have interviewed here, get ranked, and then you do the same with all the people that you're interviewing, it seems to be a little bit more of a reliable, you're going to end up in the right space for you based on what that space is also looking for. Seems like a really good way to progress someone through training, I think.
Right. And you want to make certain that you are a good match for the site and they're a good match for you.
Right, yeah. And we don't talk about that a whole lot. I don't think we talk about it enough, I should say. And it's something that, for example, in my experience with volleyball, in college volleyball, that's a big deal. You might say, oh, well, I'm good enough to play at this school. And you can put any sport in the place of volleyball. I'm good enough to play at this school, so this is where I should go. This is my NCAA Division I. I'm that person, and don't take into consideration the other factors and also what that place, that school, that program, that team is looking for. A lot of people, whether they're not honest with themselves or not honest with where they're going on their visits or interviews, end up in a place where their skills fit and their aptitude fits, but maybe facets of their personality don't.
Exactly.
And so it ends up being a miserable process. So, but Duke was your first match. So what about that was, I guess, stands out paramount in your training and whatnot? And you said it was an internship, right?
Internship, yes.
So what was the big thing that you took away from Duke prior to coming to your postdoc here that still stands out that you utilize the most? If I could put you on the spot.
Yeah, I guess augmenting my skills in being a good clinician, especially working with patients with chronic pain. During graduate school, we have to do rotations at specific practicum sites. And so the ability for me to work directly with patients with chronic pain was somewhat limited during graduate school just due to a lack of accessibility to those specific populations. So internship was really where I was able to kind of delve into that particular population and just to kind of hone my clinical repertoire.
And was chronic pain an interest to you even in graduate school? Like you had decided at that point, this is already where you were headed?
Absolutely, yeah. I developed my interest working with pain probably prior to kind of pursuing a PhD. So I actually have a master's degree in clinical psychology separate from my PhD in clinical psychology at a different institution. So it was during that time when I started to express some interest in working in the field of chronic pain.
What sparked that interest?
Great question. It was actually probably due to some of my own experiences with pain that kind of fostered that interest. So, back when I was in graduate school working on my master's degree, I really had an interest in health psychology. And because during my undergraduate degree, I had a double major in psychology and biology. And so I'd always knew that I wanted to meld the two fields together. And so when I was pursuing my master's degree in clinical psychology, I became interested in health psychology and being able to work with medical populations in a psychological perspective. And so I actually, because of my interest in pain, it really kind of fostered from my experience with endometriosis. And so I think that's kind of where it began. And then I got accepted to a laboratory that worked with pain psychophysiology. And luckily I really enjoyed it. So I wanted to, keep doing that and knew that my, where I saw myself was in the field of pain.
That's interesting. Being relatively new to pain myself, I'm always intrigued by what is the catalyst to put people on the road specifically to study pain in the way they do. Because, obviously, when it comes to pain research and pain treatment, there are pharmacologists that don't ever deal with the psychological side of pain and of chronic pain, and that look for treatments that are exogenous, drugs. Obviously, the psychology of pain is a continually growing field and with a lot of recent findings. But I think a lot of people, and I'm certain that I can speak for our audience as well, a lot of people, that's not their first thought. When you think pain, you think, well, opioids or drugs or physical therapy. They don't think to the psychological aspect. So with your interest, was it with psychology first and then pain, or pain then psychology, or what really turned you down that road as far as delving into pain research and treatment?
Well, I think psychology came first and foremost in that process. But, I know from my own experiences, but also looking at the experiences of patients that I worked with during practicum who also had chronic pain. It was at that point that I realized that we can do so much better in terms of treatment. Pain has such a negative connotation to it, even to this day. And I knew that I wanted to be involved in that. And I wanted to be an advocate for people that did have chronic pain to, create awareness and to understand it more and to be able to get involved in the treatment aspect so I can help kind of develop better treatments for people so that they can have a better quality of life.
So you said that there's a negative connotation associated with pain. Are you implying that shouldn't necessarily be the case?
Yeah, absolutely. You have to think that we're working with human beings. And, when I talk about a negative connotation, we tend, or at least, I think the field may think of chronic pain as, these are the people that are the catastrophizers. And so these are the people where it's difficult to help them because pain is very complex. It's not just a physical experience, it's a socio-emotional experience as well. And so when you think about all these factors that can impact pain, thinking about the treatment perspective, it does become a little bit more challenging. And so, which probably is why I kind of shifted some of my research into really appreciating these protective factors, resiliency factors in the midst of chronic pain, because it does have such a negative perception of the condition.
Do you think that, so before we get into resilience, is that something that affects people's, and I think I probably already know the answer to this, and our listeners can as well, but is that perception and how negatively or positively or even neutrally and objectively people who are in pain view their pain, does that affect their pain experience and the outcomes of their treatments, and how heavily?
Yeah, pain has a huge psychological process to it, and you can imagine that pain produces negative emotions. It's more highly correlated with symptoms of depression and anxiety, etc. And on the flip side, there's also this belief that these negative thoughts are also associated with chronic pain severity and disability, as well as other outcomes as well. So it has a bidirectional influence to it.
Is that what maybe makes the treatment of pain using, pharmacological approaches, drugs and whatnot, is that what maybe makes that less effective, is the fact that there's just so much else going on?
I think so. I certainly do think that that's a salient factor. Mm-hmm.
So let's talk about resilience then. Most of your research currently is based on resilience. So in what respect? Obviously, I think a fair amount of people would understand the topic of resilience, but how does it relate specifically to pain?
So in general, I think the field of pain has been inundated with assessing vulnerability and risk factors associated with pain. And I became mainly aware of this during my graduate studies and just looking at the literature. And during that time, I didn't do a lot of work in the field of resilience. It was only until I transitioned to my postdoctoral fellowship here that really started to pique my interest. And just knowing that, working with patients with chronic pain during internship and even practicum, I found that certain people tended to do, quite well. They were engaging in activities that they really enjoyed and found meaningful.
Despite the pain.
Despite the pain. And of course, there was a lot of individual variability in that. Some people didn't fare as well. But what I did find is that people with chronic pain had a lot of inherent strengths. But you didn't see that a lot in the literature. And so it was during my fellowship that I really started to kind of delve into that and started to look at processes such as positive affect and optimism and how that can impact the trajectory of pain.
Okay. And so when you talk about the attributes or the aspects that they had, can you elaborate on that a little bit more? What are some of the things even then before you delve very much into your own research? What was already out there on this topic? I mean, did you model your interests or pick up where another researcher left off, or is some of this novel to you?
So one of the first projects that I did was the development of a hope-based study. It actually stemmed from a research experience that I had in a practicum site during my graduate school time. And I was actually working with a clinician that was interested in the concept of hope. And she came from the University of Kansas, where a lot of the original work on hopeful thinking stemmed from. And so during that research project, we would go to summer camping programs for kids who had various chronic medical conditions such as end-stage renal disease, cancer, HIV, etc. Mm-hmm. And we looked at hopeful thinking pre and post this camping experience. And we found that hopeful thinking was actually augmented after these kids would kind of transition through these various camping experiences. And so when I came here, that study really stuck with me. And I wanted to do something with that. Mm-hmm. And to develop an intervention that was based upon hopeful thinking, which kind of stemmed from Charles Snyder's work on hope as this goal-oriented process that consists of pathways and agency, which is really essentially the development of routes or pathways to pursue goals, and also the mobilization of efforts to achieve those goals. So you can imagine that some people may not be very good at goal setting. Mm-hmm. If they are, then there's some people who they can't visualize the routes to be able to achieve those goals, mm-hmm. which will stunt goal progress. Or people may be good at thinking about ways to achieve their goals, but maybe they just don't have the energy, or they're not able to kind of mobilize those efforts to achieve the goals that they set out for themselves. So I actually developed an intervention. It was funded by the American Pain Society, and we looked at that in temporomandibular disorder. And we developed this 3-session brief intervention based upon the concepts of this hope theory. And we found that it was a small pilot study, so mm-hmm. you have to, I always like to caution people on interpreting the results from a pilot study. But right. But what we found was very promising in that we found that some quantitative sensory testing measures, such as heat pain sensitivity, was actually changed after people went through this hope intervention. And then we also found some differences in various psychological factors such as catastrophizing that were reduced after going through the hope intervention. And this was compared to people who went through kind of a basic pain education treatment. So from that was the starting point for me. And then after that, it just kind of burgeoned into different other studies looking at various mechanisms that may underlie resilient processes in chronic pain, to now developing more treatment approaches that foster more of a kind of a resilient paradigm.
Okay. Well, I actually want to circle back for a second if I could, because it's really intriguing. So with the concept of hope. So you said that these kids would go to camping experiences, mm-hmm. and their outlook or their hopefulness for their own future, I assume is what you mean, would improve. Were those camps specifically purposed to affect that, or was it something about the experience, the socializing? What was it that grabbed your attention that you tried to replicate in the intervention later? What was it about the camps that you think really affected the kids?
Well, I mean, the camps really try to kind of foster, different principles. If I do recall correctly, I believe that hope was one of those principles, and this varies across the camping programs that we went to. But they get them involved in various social activities to keep their mind off of, the medical illness that they're experiencing.
And so, so in a way, it was just focusing their attention elsewhere. Really, were there specific things? Am I correct in saying that? I mean, it was just really not to trivialize or minimize it, but obviously, if you have one of these conditions, that it takes the spotlight in your life, I would imagine, especially as a kid. It can kind of steal the fun out of being a kid,
Absolutely.
And so is it just a matter of finding ways to allow those kids to be kids and to take that out of the spotlight as opposed to specifically saying, okay, well, these are the processes of setting goals and so on and so forth? Or?
Yeah. I mean, if you get into the specifics of hope, I mean, those specifics weren't really capture during the experience. It was really just a way for kids to enjoy themselves, enjoy life, socialize with other kids who may be going through a very similar circumstance.
Right. So is that what you pulled out of it? So to translate from that to the intervention for your pilot, is that something you can talk about a little bit? And what specific elements of the experience, the social experience at the camps, did you try to capture and use in your intervention?
Great question. I think what I glean from that is really just the essentials from positive psychology, that there's so much more than the vulnerability aspect. And hope was something that I was familiar with. I'd worked with it before. There wasn't really a lot done in terms of psychological interventions that focus on hope as a target. And I think that's where I had started thinking about developing that even more because there wasn't literature on that. There was one other study that had used hope as an intervention target, but it was a single session intervention. And so mine wanted to kind of span out over a few different sessions and then look at that in the context of chronic pain. And so it was really just something that I was familiar with. I thought that there was something that we needed to do with this particular construct.
And you said that it changed some of the outcomes. And again, for those who are, and I have to act as a bit of a proxy for all of our audience, of course. So there may be some people who are not familiar with why you don't take the results of a pilot study too much to heart. Maybe actually, would you like to talk about that a little bit more before I ask about the results of the pilot study? But why? What differentiates a pilot study from a larger, say, like a clinical trial or something like that?
Pilot studies can certainly be clinical trials, but pilot studies are usually, a smaller number of participants. So it may not be fully representative of a population, and it can lead to imprecise, estimates in terms of what exactly may occur during a full-blown clinical trial. So that's why you do these pilot studies to determine, is there a signal of an effect? Can we use the results and be able to kind of grow upon that into a full-blown clinical trial? So it's really just kind of an initial step to determine, is this even worthwhile to be able to pursue?
So for those, we were talking prior to this conversation about social media and the current climate. So for those who are out there looking for evidence, empirical evidence to support their beliefs, maybe that'd be a good indication that pilot studies aren't where it's not the basket that you want to put all of your eggs in to support your confirmation bias.
Right. And essentially you would want more than one study to be able to, you want to replicate findings.
Okay, so, but you did, now that we've cleared the air on that, you did mention that with some of the QST, the quantitative sensory testing, and we've had other guests that have talked about that, but I think that it's probably important to discuss why that's important, and maybe even a little bit of details. You said with heat pain sensitivity, that changed over the course of this intervention between your groups. Maybe we should take just a moment and talk about quantitative sensory testing, maybe just in hone in right on heat, because that's the one that you brought up. What's the process? How is it done? And how do you interpret those differences? What changed in these study participants as a result of the intervention?
Well, so for quantitative sensory testing, you can do this in so many different ways. There's a lot of different modalities. You can assess the experience of heat pain sensitivity. You can look at cold pain sensitivity. We can do that with placing their hand in a bath of cold water, and there's other methods of which to assess that as well. Pressure pain sensitivity, so using an algometer, applying painful pressure to various sites on the body. And generally what we've done in the laboratory is we assess not only their perception of pain, so their pain rating, and we usually use a numerical rating scale for that, so a 0 to 100 numerical rating scale. But then we can also assess thresholds and tolerances. Threshold is the point at which people first experience pain, and tolerance is the maximum amount that they can tolerate. So there's various metrics that you can examine in terms of this paradigm.
So with these participants, what changed in their heat pain sensitization?
So we found that heat pain tolerance changed from pre to post, and there was a significant difference between people who were in the HOPE intervention as compared to pain education. So we found that people who were involved in the HOPE intervention, they actually experienced less heat pain sensitivity, so higher heat pain tolerance from pre to post.
Okay.
And we also found some differences in various psychological measures, such as pain catastrophizing, so that also reduced from pre to post for the HOPE intervention. And then HOPE obviously increased as well. And
you've mentioned catastrophizing a few times now. Explain that for everybody if you could. What is pain catastrophizing? So
pain catastrophizing is, it comprises various components. It's where an individual may magnify or distort the pain experience. They may ruminate, so have excessive thoughts regarding pain. They also may feel helpless in regards to pain as well. It's probably one of the most, I would say, robust predictors of pain and disability, and very heavily studied cognitive process.
Is that a normal point or a normal aspect of pain in recovery, or is it something where if someone is catastrophizing at all over their pain, that they've strayed from a healthy trajectory? Or is there a point where, like, well, okay, this is what we would expect, but beyond this point, now that's bad? Or is all of pain catastrophizing unhealthy?
I think that it could be normal in terms of people having, negative thoughts regarding pain. But there is a point to where it becomes excessive and where it can actually impede adaptive pain outcomes.
We talked with Dr. Roger Fillingham very early on, our first episode ever, and he conveyed his favorite descriptor of chronic pain, which is pain that's outlived its usefulness. But from a psychological standpoint, pain does have some kind of, and I'm not a psychologist, so please feel free, of course, to correct me if I'm wrong, but it seems as if pain has, from a psychological standpoint, a protective evolutionary purpose. And that, well, if you do something that has injured you, that's harmed you in some way, it might be safe, at least for a time while you're recovering, to not repeat that activity or find yourself in that situation again. So is that also a little bit of catastrophizing? If you think, well, if rumination, for example, say you're a little kid and you touch a hot stove and that stove is red. So from that point on, you've maybe gone through that memory a couple times in your head, and you avoid touching red things in general, whether they're stovetops or not. That seems to have some kind of protective component to it.
Absolutely.
So is that, would it be safe to say then by that rationale, a little bit of catastrophizing might not be the worst thing?
Yeah, again, I think it depends on the level or degree of catastrophizing that one experiences. I mean, whenever we talk to participants that come into the laboratory and go through our studies, we tell them that pain is very adaptive, and echoing what you just said, it has a survival mechanism to it. You certainly wouldn't want to touch a hot stove and keep touching it, right? Because then you're going to injure yourself. It also alerts you when danger is present. If you step on a piece of glass, then you don't want to keep stepping on it. So it alerts you when something has happened, when there's damage. I think probably maybe the biggest point here is maybe a little bit of those thoughts regarding the threat value of pain may be helpful, but there comes a point to where if you're ruminating constantly or you're catastrophizing, you're magnifying the experience a lot to where it's impairing things for you, you're not able to engage in adaptive behaviors, adaptive self-management behaviors. The thoughts are encompassing your life a lot to where you're not able to focus on other things. Then that is problematic, and that's where catastrophizing is maladaptive.
So maybe like the difference between a fear and a phobia, for example. Like if I'm on a tightrope, I would have a fear of falling. But if I have a phobia of heights where I can't even be in, on a balcony somewhere, well, that's different, and it's maybe a little bit more irrational. So maybe there's an irrational component at some point to the catastrophizing where.
Exactly.
Yeah. Okay. And you said, but that's also predictive with chronic pain. So am I correct in saying then that people that rate high on catastrophizing scales, then you can say, well, these people are perhaps more prone to chronic pain states? Is that what you mean by that?
You do see a relationship between, chronic pain, various chronic pain outcomes and pain catastrophizing. It's associated with adverse outcomes, such as people who catastrophize tend to have higher pain severity. They tend to have lower quality of life. They're more disabled by their pain, have lower functional performance, functional capacity. Amidst a lot of other different outcomes, you also see it highly correlated with anxiety, depression, other negative psychological variables as well. And in the context of resilience, you do see it also inversely correlated, and at least we found that in our particular studies that catastrophizing is inversely correlated to positive affect, optimism, other positive psychological variables such as those.
So if we springboard from the work that you did on hope to where you are now with resilience, what's the main focus of your work now? And it could, of course, a recent publication or even just your interest, where you did a really fantastic job of laying a foundation for what got you to where you are now. How are you then building upon that? What's the focus now?
So I would guess there's probably two lines of research that I'm really targeting right now. One is the development of clinical interventions that are based upon this concept of resilience. So we have two clinical trials ongoing right now. One is with older adults with chronic low back pain. And so we have developed a group-based 7-session intervention that is focused on augmenting certain resources of resilience, such as positive affect and emotion, pain acceptance, self-efficacy, and hopeful thinking. And so we take participants and then we engage them in various activities that are focused on those 4 concepts.
So that seems to be based on, of course, resilience is a good thing, and the more resilience, the better. But it seems as if either you're under the impression or you've realized that you can change people's resiliences. So how effective are some of these methods, I guess, of improving resilience, and is it dependent upon age? Is this a can't teach an old dog new tricks kind of thing, or is there a developmental stage that trying to affect resilience seems to be more effective, or it takes root a little bit better?
Yeah, that's a great question. I don't feel like there is an age limit on increasing people's capacity for growth. In terms of looking at, these types of interventions in the context of age, that hasn't been done because there hasn't been a lot of various intervention paradigms that have been developed. There's just been a small handful of studies that have focused on promoting resilience through kind of positive psychology concepts. Mm-hmm. And so I think that we're really, in terms of the field, we're really in its infancy in terms of kind of understanding the processes that are involved and whether these interventions are viable for various chronic pain populations.
For what you've seen so far, how, and understanding, of course, like you just said, this is still pretty early on, but is there any indication of how permanent some of these changes are? If you get someone and they go through, you said a seven.
For our particular study, they go through 7 sessions.
Okay, so 7 sessions. Let's say a person comes in for 7 sessions, and just speaking hypothetically, of course, because I assume this is ongoing right now.
Yes.
Still, okay. Mm-hmm. So you haven't had the opportunity to follow up and see how they are a year later. But
Correct.
what do you think, based on, is anybody else doing this work? Do you have any basis to say, well, we think that this might be a pretty permanent change in people, or is it dependent upon continuing sessions?
So first of all, again, there's only been a small handful of studies, and the long-term follow-up to look at sustainability of effects hasn't really been done. For the handful of studies that have been done focusing on various positive activity interventions, they have found significant effects in certain variables over a period of 3 months.
Okay.
But to look at the sustainability over a longer period of time, such as 1 year, hasn't really been done. And again, we only see these effects on certain variables, and it really does depend on the outcome of interest for the particular study as well.
But 3 months, that seems to be impactful, if especially if you take into account that chronic pain seems to often result from acute pain that doesn't go away. Not always, of course. But if you think about it, a lot of times there are plenty of conditions that you can, especially acute conditions, that you can recover from over a few months and maybe get past that point where the pain lingers and turns into something else. So is this possible that an intervention like this could be implemented when somebody breaks a leg or has a back surgery or goes through cancer treatment that's a shorter term cancer treatment? There's a point where you could say, okay, well, as part of your treatment, you're doing all of these other things to manage your pain as you recover. This is something that we also recommend that you do at this stage as you're weaning off of another treatment or something like that to increase the likelihood that your pain will not transition into a chronic pain state. Is that something that you envision?
Absolutely, and that's actually a future direction of work that I would like to transition to in some point.
Okay, you're welcome. No, I'm kidding. No, that's I think that's really fascinating because we talk a lot, or I've talked a lot with our guests, and even amongst pain research, because this is relatively new for me also. I'm applied kinesiologist and physiologist, and so focusing that lens within pain and aging is relatively new for me. So I love to hear about all of these different approaches to pain treatment, but there are still some people who, their research is at a point where it's like, well, this is great, and we think we see this, and it may someday be used for whatever, but this seems like it's much closer to a translational and clinical application as far as treatments go, and I think that's really exciting.
Yeah. It's I think it would be certainly beneficial for people who do, like you said, have maybe an acute pain experience or going through a surgical procedure and being able to target certain concepts, intervene ahead of time. So maybe that recovery process is a little bit easier for them.
Yeah, I wonder if there's, and maybe you can answer this, but if there's any research into the point where people are most vulnerable in their pain experience, in maybe deviating from that healthy recovery from acute pain. And I know that there's a lot of pain phenotyping research, and we had Dr. Cruz Almeida on, but understanding how different groups experience pain, maybe taking it another level to say, okay, well, not only are these groups at higher risk for developing chronic pain, but this is specifically when they're at that highest risk, and then maybe that's a point for this type of intervention to occur.
Yeah, I'm not really certain on the literature in that particular area, but I do know, I mean, you're speaking about precision medicine, which I do think is an important kind of avenue in terms of where pain research is going, and being able to phenotype various groups, looking at those various characteristics that may be predictive of how people do during treatment. What are those characteristics that are going to be most applicable to the treatments that you are applying to them? So I think that's kind of an important future direction.
Yeah, it's got to be a little bit more difficult from a psychological perspective because there's so much variation. So, physiologically, when we talk about acute pain, well, we know from a point where there's some kind of tissue damage, or in some cases the possibility of tissue damage. But let's stay on a specific event that is an acute injury. It causes damage, and then physiologically we know pretty well what happens after that, with regard to some of the chemical signaling that occurs, and the process of rebuilding and scar formation, for example, and we know the stages, even maybe somewhat recently, differences in inflammatory stages and how important they are, and you talk about precision medicine, you can, as a result of that, allow some of those processes that are supposed to take place, even if they are somewhat uncomfortable, to occur to ensure a full recovery, or at least as full a recovery as possible. I would imagine it's a little bit more difficult on the psychological response to pain and injury, but I wonder if there are certain stages, whether it's coping stages or whatnot, that would help to target some of those things.
Yeah, I mean, I certainly don't see why not. I mean, and also, is you can also look at like readiness to change. Are people wanting to engage in those types of therapies? Are they ready to? So it becomes complex because you do have a lot of different coping processes, psychological processes that you would have to kind of factor in that.
Yeah, and it seems like the mistakes that have been made in medicine tend to arise from one pill for any malady. It's this, you have this, so I'm going to give you you have the flu, so here's an antibiotic, when that may not actually have any effect and could have negative side effects that make you worse off. With interventions like this, can you think of anything that might be, and I think this is a stretch after hearing you describe the interventions and self-efficacy and hope but is there anything that you could think of as maybe a negative outcome for these types of therapies that you would have to be cautious of?
There's not a huge risk effect from these types of activities. Most of the time, we're trying to boost positive emotions. So you could probably, appreciate that, that really is not going to have a lot of harm associated with it. Although, interestingly, there are some of these positive activity interventions, resilience-based interventions, which they did find has had a negative impact on certain populations, such as individuals who had major depression and suicidality. So you do have to be very mindful about the population that you're working with and the outcomes that you're interested in, because there could be setbacks depending on what that particular cohort is.
What do you can you detail a little bit of what happens in those populations and why you need to be cautious with this type of therapy or intervention?
Um,
What effect does it have differently on them than it would maybe somebody who's not depressed or suicidal?
yeah, that's a great question. I'm trying to recall. This was some research that I had heard at the International Positive Psychology Association, and they had talked about how they had brought these individuals in with depression, and I think through the activities it had actually increased hopelessness. But I could be recalling
Sure,
that
sure, sure.
incorrectly, but I do recall that it specifically had a negative impact on individuals who were high in suicidality. But I'd have to go back to the original paper to investigate that a little bit further.
Well,
But I mean, it just speaks to you do have to be thoughtful about what types of processes you're trying to boost with these therapeutic paradigms, resilience paradigms, and what type of effect that will have on your populations of interest.
Yeah, and I don't mean to put you on the spot with that. I understand, and I hope that all of our listeners and followers do as well, that you don't have all of this information on hand all the time. It would be impossible. You just need to know where and how to find it and when to look for it. But I do appreciate you commenting on that. So also, and we kind of hinted and teased around this a little bit earlier, but so let's look at the flip side of that. There are populations where you need to be considerate of applying positive psychology. What populations does this really stick with? I asked about age earlier, but are there other subgroups or demographics where this is a particularly effective treatment?
Yeah, so these positive psychology interventions have been used across a wide variety of various groups to enhancing work productivity, reducing absenteeism. So you're getting more into the kind of IO side of things.
What do you mean by IO?
Industrial organizations, so looking at various organizations and how you can boost productivity and also, positive relationships amongst coworkers. It's also been used in the school system, so boosting productivity and positive emotions in children as well. But then also various conditions. So I'm trying to think of other medical populations that it's been used with. Judith Moskowitz has been using a lot of these therapeutic interventions for various populations as well. I believe HIV has been one of them. You can also use it on, people with traumatic experiences. So the list goes on and on. It's been used quite heavily, although you don't see it very much in chronic pain.
Yet.
Yes.
Okay.
Yeah.
Well, and this is early on, but it seems to be the in vogue approach now is to look at combined therapies. Are there other types of therapies, psychological interventions or otherwise, that you think that this might be particularly effective in combination with, where you maybe with the positive psychology interventions along with something else get a synergistic approach or a synergistic result rather that's better than the sum of the parts?
Yeah.
Just speculating, of course.
Yeah, this is actually kind of another area of interest for me is to kind of look at resilience across these various kind of multi-system processes, which has an intervention interface to it as well. So so the question is, do these positive psychology interventions, do they hold up alone to be a standalone therapy for people with chronic pain? Or should we be integrating them within existing types of therapeutic treatments, such as cognitive behavioral therapy, acceptance and commitment therapy, maybe mindfulness meditation or physical therapy? I would anticipate that these types of therapies would probably fare better if they were already integrated within an existing treatment that we also know produces some adaptive benefits for people with chronic pain. But these are things that still need to be parsed out.
And without me really having a firm understanding, as I'm not a clinical psychologist, of the specifics of the interventions and whatnot, they're occurring in a room like we are now, I assume, where you're talking and sorting through feelings and emotions and memories and maybe visualizations.
Mm-hmm.
I have to wonder, say with a physical therapy perspective, for example, being able to, if self-efficacy and hope for a positive outcome are features of this intervention, if coupling the awareness of that possibility and instead of visualization, actually having some kind of physical outcome where you say, okay, well, I know that you can do this. It's important that you know that you can do this. And then putting them in a situation to succeed in doing that, even if it's in small incremental steps. Do you think that might augment the effect?
Yes, absolutely.
That's so in addition to that, what else, you talked about precision medicine and phenotyping and whatnot. I like to conclude our conversations as often as possible with looking just over the horizon. What do you think is next, specifically with resilience in this type of intervention, specifically with pain and pain treatment and pain research? It doesn't have to be necessarily a breakthrough in a treatment, but what's just over the horizon? What comes next for you looking ahead?
So I guess one kind of avenue is really trying to look at, the feasibility and acceptability of these interventions. Are they viable? Can we move the needle a bit on pain-related outcomes? And then, also comparing these to existing treatments, which one is going to have the more robust effects on the outcomes of interest? And like we talked about before, can we possibly intervene at a very critical time point to where we are essentially producing better pain outcomes longitudinally? So, integrating maybe brief resilience-based interventions. So I think that's one avenue. Another one is that I've been working on is trying to understand exactly what this concept of resilience is, which in general, when we think about resilience, it's kind of this adaptability to stress and adversity. But the definition really does vary across various fields and disciplines. And in most cases, what we found in the literature is that resilience has been defined as a trait-based concept, which ignores the malleability of resilience, and it takes away from being able to intervene on it if it's a pure disposition.
Right.
Resilience has also been defined in terms of mechanisms that promote kind of adaptive, pain beliefs, psychological beliefs. It's also been defined in terms of outcomes. So whether people recover from whatever adversity they're experiencing, whether they have sustainability, so they still engage in life goals, or whether they experience a sense of growth from whatever stress or adversity. So did they gain meaning from whatever that experience was? But what we find in the literature is that when people look at resilience, they'll look at one mechanism, and which usually focuses on psychological processes such as self-efficacy or positive affect. And what we're trying to do with our research is look at resilience from a multi-system perspective, because we know that human beings are very complex, and they're shaped by psychological, physical, various behavioral factors. We know that exercise and sleep are advantageous for pain outcomes. Also looking at the social atmosphere of what a person lives in, various biological processes, and looking at the synergy of those various domains and how they interact with one another. So what we're trying to do is capture what resilience is by looking at all these various factors that contribute to resilient functioning.
That seems like a pretty big task.
Yes, it is. Yes, we're at the very beginning stages of that, but very excited. I'm also working with a colleague, Dr. Kimberly Sabile, and Amber Brooks from Wake Forest, and we're trying to develop a resilience index that can be used clinically, but then thinking about all these various factors that contribute to a resilient capacity.
Yeah, so we had Dr. Starbooker on previously, and we actually modeled some of our work that we're currently undertaking on some of your work in trying to characterize, in our case, it's movement-evoked pain as opposed to resilience, but using some of the same methodology from an observational perspective to see if you can really kind of find domains and at least for us as a step toward developing an index of movement-evoked pain. But I think that stuff is really interesting, and it's easy to particularly from a non-academic perspective, when you think of research, to really hone in on, this magic pill or this magic intervention, but really just some observational work in looking at, what is, because you can't really affect something, very well if you don't understand what it is and the characteristics of it. So I think that's really fascinating work. But thank you for coming on and sharing some of what you're doing now, and certainly educating me. So I'm hoping that I'm maybe somewhere in the middle of the road as far as our listeners. So if I learned something, at least half of the people listening did also.
Hopefully so. Yeah. Thank you.
So do you have a website for your lab or anything that if people are interested in either participating in research or just learning more about what you've done, where they could find some of that information?
I have a faculty webpage, but not a specific page designated for my lab. That is on the to-do list, though.
Okay. Well, we can certainly share that, and by the time we get done with this video, we'll have that right at the at the bottom of the screen.
Excellent.
But again, thank you so much for sharing some of your time with us.
Yeah, thank you for having me.
Thank you for joining this episode of The Price of Pain. Opinions expressed on this podcast are solely those of the host and guests, and not representative of the University of Florida or parent institutions of our guests, unless specifically stated. You can find more information about Price on the World Wide Web at price.ctsi.ufl.edu. And keep up with our researchers on social media by searching Facebook for UF Price, by following @UF_pain on Twitter, and Price of Pain Podcast, all one word, on Instagram.